welcome back to another video. It's your girl Susan here, back with another amazing video. If you're new, welcome to the channel. My name is Susan and I create videos on faith, lifestyle, dance and fashion. And if you're a returning subscriber, thank you so much for coming back. I really appreciate you guys, and yeah, let's keep growing. I hope you enjoy the channel. Road to 1K subscribe, and yeah, we're gonna have a giveaway then. So currently it's 21:30 and I'm basically on call in pediatrics. Yeah, this is the 15th of July 2024 and I just got back from reviewing 2 patients. So it's been a quiet call actually. I only had these 2 referrals who came from Maramba. That was like about an hour ago or so. Yeah, one had severe acute malnutrition, a 1-year-old 5-month boy, yeah, who came in with severe acute malnutrition and also admitted for the same with some dehydration. So the child presented with diarrhea which began 2 weeks ago. He would have 3 episodes a day, but today he only had 1 episode of watery diarrhea, non-bloody mucoid inconsistency, no vomiting. What else did he have? He also had a high temperature of 38 degrees, sunken eyes, and poor appetite. Yeah, irritable. Yeah, so I admitted the child for severe malnutrition. And I'm gonna get into how you make the assessment for malnutrition. Okay, so basically you need to assess certain parameters, okay, that are called the anthropometric measurements, which include like the mid upper arm circumference, which should be at least 11.5. okay, so anything lower than that would signalize some form of malnutrition. Okay, so you need to assess that using the mid upper arm circumference tape or the mark tape. Yeah, and then you also check the height of the child. Okay, you check the height, you check the weight, because these are the things that you're going to use when you're trying to assess if your child is if your child's weight and height are correlating for their age. Okay, so you're going to use something called the weight for height and the weight for age scale chart that you're going to use to assess to see if the child is actually falling below the standard deviation for their required weight or height. Yeah, I'll insert everything somewhere here so that you guys can understand what I mean. And then there's also a chart that you have to fill in, which is also going to help you in the management of SAM. Okay, it's going to help you to assess and see if it's SAM. So it's basically called a critical care pathway chart for severe acute malnutrition, and I'm going to run you guys through it. I have them with me here, so I'll run you guys through it on how to like use it and record and use it to manage your SAM and diagnose your SAM. Okay, so yeah, so basically, like I was saying, for severe acute malnutrition you need to use a chart called the critical care pathway chart, as you can see, for severe acute malnutrition. So this is basically just going to help you in your management of severe malnutrition and to assess and to diagnose your SAM. Okay, so the first details you have to put there is like the name of the patient, the sex of the patient, how old the patient is, date of admission, you indicate it there, your time of admission, you also indicate it there. Okay, this first part which says signs of severe acute malnutrition, so you have to assess, is there severe wasting? Okay, so basically you just check the appearance of the baby. Is there muscle wasting? Is the abdomen abnormally large? Are the bones prominent? Are the bones visible? Okay, you assess. If it's there, you say yes. If no, you just leave it out. Is there bilateral pitting edema? Usually there's some children that present with bilateral pitting edema. Okay, so you want to assess. If there is no edema, you circle there. If there is mild edema, that's +1, you circle moderate and severe. Okay, then is there dermatosis? They also present with skin conditions most of the time, so you assess. If it's there, you indicate likewise this child didn't have any dermatosis. Then you indicate the weight there, indicate the height in centimeters, you indicate your mid upper arm circumference. Okay, I put it in centimeters here because that's what we mostly use. Yeah, and then you come and indicate your weight for height score. Okay, using this, there's a chart called the Z chart. Okay, there's a chart that you use to assess the weight for height. Like I inserted them earlier on. So for this child, he was already falling below 3 SD, okay? So he was at minus 3 SD, meaning he was severely malnourished, okay? Yeah, and then you indicate your temperature, okay? Then here you're supposed to indicate your blood glucose, okay? But then we ran out of glucose sticks, so we couldn't indicate. But then for these ones in malnutrition, you have to assume that they already have some form of hypoglycemia, okay? So you just give them a bolus of 10% glucose, okay? Whether you can take orally, you give. If not, you give by NGT, okay? Yeah, then there's that formula which shows you how to calculate, okay? If the child is lethargic, okay? You just follow that instruction. It's simple and straightforward. Yeah. And then the HB, if it's there, if it's available HB, which is the latest HB from, let's say, the referring clinic, or you already did one, you can indicate it there, okay? For us, we don't have one yet. We're waiting for the one that they did from the referring clinic, okay? Yeah. Yeah, blood type, if you have it, you also indicate, okay? Yeah. If the child's HB is below 40 grams, then you can, so it's supposed to be below 4, okay? So if the child has got severe anemia, then you can transfuse them, okay? Following this same protocol, okay? 10 ml per kg, yeah. Then you also check the eyes, okay? Most of the time they can present with eye signs like abnormal eye signs, okay? Like beetle spots, these corneal inflammations. You assess if the child has any of these things, okay? If nothing, then you indicate there also. Measles, yes or no, you indicate, okay? Signs of shock, okay? So it's very important. You have to really assess your child in malnutrition to make sure that you don't have any signs of shock, okay? Because these ones can present with shock most of the time, okay? So for me, my baby didn't have any signs of shock, thankfully, but then most of the time they can come lethargic with cold peripheries. Their capillary refill time would be very, very, very slow, okay? Like less than 30 seconds, okay? So capillary refill basically are just pinching the tip of the finger and then you let it go, and then you see how soon it comes back to red, okay? If it delays, it's supposed to usually come back in less than 3 seconds, okay? Like for example, you can see here, and I let it go, it's already come back, okay? So usually in malnutrition, that capillary refill is reduced significantly, so you have to assess and check for that. Check the pulse. How is the pulse? Is it weak? Is it fast? Okay, are they unconscious? Are they lethargic? What else? Yeah, so all these signs, if they're present, that means the baby is in shock, okay? So if they're in shock, then you have to give them IV fluids, okay? And the way to calculate the IV fluids is 15 ml per kg body weight, okay? And that's how much you're gonna give, okay? So this whole table just shows you how to do it. It's very easy and straightforward to follow. You can understand it, right? Yeah. So next is this part which says you check for diarrhea, stool, blood in stool, or vomiting, okay? Does a child have any of these? My baby had diarrhea, okay? So if any of these three are present, then you have to start the child on Rizomal, okay? So this child will already commenced on Rizomal, and that we give that Rizomal 5 ml per kg body weight, okay? Which gave us a total of 37.5, but we rounded off, that's 38, okay? So this child is gonna get in Rizomal 38 ml, okay? Yeah. And then other things we'll give the baby are antibiotics, okay? So I put the baby on X-Pen, gentamicin. So X-Pen you're calculating at 50,000 international units per kg body weight, okay? And you're going to give that 4 times, so that's QID IV, okay? That's why you're giving your X-Pen. For gentamicin, you're using 5 milligrams per kg OD, okay? And you're gonna give that just once, okay? That's why you're gonna calculate your antibiotics. So if you have antibiotics, you indicate them there, okay? Yeah, these other stuff the nurses will fill that, okay? You don't have to worry about that. You just fill in the part for antibiotics, okay? If there are other medications that you're giving, you come and indicate them here, okay? Like for example, I put this baby on paracetamol because he had a high fever, okay? So paracetamol 15 milligrams per kg body weight, and you give QID per oral, okay? Then you also put the baby on zinc, okay? Because you know this is malnutrition, so you need to give them the zinc, you need to give them the potassium, you need to give them the magnesium, okay? All which I've indicated here. So the zinc, since he's less than 2 years old, you are giving so the zinc, since he's 1 year 5 months, we are giving 10 milligrams, okay? OD per oral. Then slow care, we're giving 300 milligrams OD per oral, and magnesium, we're giving 1 tablet OD per oral. Okay, so any other medications that you're giving the baby which are not antibiotics, you come and indicate them here on other. Okay, so this is basically for the nurses. They just fill in like the saturations, they check. Okay, yeah, if the sats are low like that, we can put the baby on oxygen. Okay, yeah, check the temperatures. Okay, all those things. Yeah, so yeah, that's basically how I admitted my malnutrition baby. And for usually for the rhizome or for the feeds, okay, there's a way that you have to give them, which I want to explain for you guys. Okay, so this baby, we started on rhizome 38 mils per kg, and you have to give this rhizome every 30 minutes for the next 2 hours. Okay, so for the next 2 hours, you're going to be giving rhizome every 30 minutes. Okay, and while you're doing that, you're also going to be monitoring this patient's vitals every 30 minutes. Okay, yeah, and then after 2 hours, okay, you are going to come and reassess the baby to see the hydration status. Is the baby still dehydrated as when you admitted them, or as the dehydration improved, as the hydration status improved? Okay, so if the dehydration is still the same, then you are going to repeat this same rhizome the way we've been giving it. Okay, yeah, but if the hydration status has improved, then now you are going to change the way we are giving these feeds. Okay, so we're now going to incorporate what we call F100 or F100. Okay, we're going to incorporate it together with our rhizome, so we'll be giving the 2 of them at the same time but alternating. Okay, so this feed should be given for a maximum of 12 hours. Okay, so we're going to give these feeds because this child has malnutrition, right? So and there's also dehydration, but then we don't want to cause refeeding syndrome. Okay, so we're going to start giving these feeds slowly over a period of 12 hours. Okay, so for the first 2 hours, we're going to give only rhizome. Okay, so rhizome, which is going to be given every 30 minutes in the next 2 hours. Okay, and then we'll be reassessing the vitals every 30 minutes also as we're giving the rhizome. Okay, and then after the 2 hours, we reassess the hydration status again and see how the baby is. Okay, is there still dehydration? If it's still there, you repeat the same rhizome. Okay, if the dehydration has improved or hydration has improved, then now we're going to incorporate our F100. Okay, so F100, we're going to give it together with rhizome in the next remaining 10 hours. Okay, for example, let's say I start my F75 at 22 p.m. right? So meaning at 23 p.m. I'm going to come and give F100. Okay, and then later on at midnight, I'll come and give F75 again. So basically we'll be giving the rhizome in F100 in alternating doses. Okay, so if I give the rhizome at 6 o'clock, at 8 o'clock, and at 10 o'clock, then meaning I'm going to give the F100 at 7 o'clock, at 9 o'clock, and at 11 o'clock. Okay, yeah, until 10 hours. Okay, yeah, so that's basically how we'll be giving the feeds, and then after that we'll check and see if the baby has improved. Okay, yeah, so basically for malnutrition, you just have to remember there are 10 steps of malnutrition. Okay, 10 steps which are inset here, and you have to follow those 10 steps in the management of malnutrition. Okay, yeah, so basically this is what I'm doing here. All this stuff that I'm doing, the antibiotics, the feeds, the what is or in the first steps. Okay, the first 3 steps of managing malnutrition. Basically, you're trying to correct any hypoglycemia, any hypothermia, any dehydration. Okay, yeah, so yeah, you guys just read up on it. It's not really hard. You'll be able to understand it once you keep going through, but I hope it's come a little like snippet has at least like helped you understand a bit more on the management of malnutrition. Yeah, so the other patient that I saw was a patient with cerebral palsy. He came in with febrile seizures. Any seizures or fittings that occur in a child who has a high body temperature. Okay, mostly the body temperature which exceeds 37 degrees. Okay, it can be 38, it can be 39, it can be 40 degrees. Okay, so any of these temperatures can trigger seizures in children. Okay, so this child came presenting with the same, and also he's a non-CP patient on phenobab and baclofen. Okay, baclofen is just some medication that is used to control the spasms and the stiffness of the muscles, because these children with CP most of the time have these muscle spasms. Okay, yeah, so for him we basically just gave diazepam 0.2 milligrams per kg body weight, or this IV stat. okay, just to stop the seizures and calm him down and relax the muscles, okay. Then we also put the baby on paracetamol 15 milligrams per kg, okay, just to control the fevers. And also you can also put antibiotics, okay, if you suspect like there's any cause of the fever like pneumonia. Also you can put the baby on IV antibiotics, okay. Yeah, so basically those are my 2 admissions. And then you also check the saturations of these children, okay, because they are mostly susceptible to desaturating these cerebral palsy patients, okay. So you make sure the sats are okay. If they're desaturating, you put them on oxygen, okay, and you can admit them to high dependency unit or HDU for close monitoring, okay. So that's why we admitted this baby, but he's stable, really. They're both stable, both of my patients. And yeah, that was my night so far. It's been quiet, but then if anything comes up, I'll be sure to let you guys know. And yeah, stay tuned, and I hope you're enjoying the video. So I'll catch you guys later. Welcome back to another day of the vlog. Today is the 24th of July 2024. Time check, this should be around 7:10. Yeah, I'm just about to start off for work. Fit check. I just gelled my hair into a slick bun. Yeah, leather jacket, yellow dress, yeah, and just some cute little loafers. So yeah, basically today I'll just be doing the round in neonatal ICU, and I'll try to carry you guys along and try to vlog and show you guys how we write the notes for an NICU patient, right? Like from admission to daily rounds on the patient. I'll try to show you, and yeah, I'll see what else I can try to vlog for you guys that might be interesting. But so far these past days, there's nothing that's been interesting so far. It's just been doing the rounds in NICU. Then I was in OPD last week Friday, which was really just chilled and quiet. We are basically just seeing patients with upper respiratory tract infections. That is basically the common cold. Yeah, so the only treatment we're giving was just like cough syrups, paracetamol for fevers, if any, saline drops if there's nasal congestion. Yeah, what else? Vitamin C. Yeah, basically just that. We only had like 2 sickle cell patients, one who had an HP of 5, so we just had to transfuse, and we requested for 2 units of whole blood for her. And yeah, basically we also prescribed some deltaprim, hydroxyurea, because you know these medications are essential for sickle cell patients, okay. What else? Folic acid, okay. You don't give them iron because iron is gonna cause more problems for them, so you just give folic acid, the deltaprim, hydroxyurea. If there's an indication for blood transfusion, you transfuse, of which is what we did for this patient. So that's basically been it. It's been chilled. I haven't had any interesting cases, yeah, but if I do have, I'll be sure to vlog and share the management and everything. So yeah, I hope you guys are enjoying the video. Stay tuned and please subscribe. Let's get to 1,000 subscribers, okay guys? Like I said, giveaway at 1,000k, so let's get to 1,000. And yeah, I'll see you guys. I hope you're enjoying the video. Bye. Hey guys, so time check, this was 10:30 a.m. in the morning in NICU, and here I was basically just recording my admission notes just to give you guys a run through of how you write notes when you're admitting a patient in neonatal ICU, okay? So of course you have to take down the patient's name, but since these are neonates, they don't have a name, so you mostly just use the mother's name, okay? So baby of, for example, Musonda Mulea, okay? I was trying to hide the patient's name there because of patient privacy and stuff, okay? So baby of so and so, you take down if it's a female or male neonate, you indicate how old the baby is, okay? So this child was 4 days old, okay? And then afterwards you also start you write your name, okay? As a doctor who is seeing the patient, you write your name, you put the date, the time, the word. Okay, so female neonate, 4 days old. Where did the child come from? Are they a referral? Are they self-referral? You indicate. Okay, so this child came from the labor ward for hypothermia. Okay, and afterwards you now take down your birth history. Okay, so your birth history is going to consist of the date of birth, time of birth, place of birth, mode of delivery, APCA score, and if the child is reactive or not, or exposed. Okay, after that you get your maternal history. Maternal history is basically the age of the mother, her parity, the gestation age, the LMP, and is the mother reactive or not. Okay, then next you're going to get your vitals on admission. Okay, then afterwards you do your examination. Okay, so that's basically what I've written there. Your general examination, CVS, chest, abdomen, CNS exam, GUT, ANAS, okay, and the like. Yeah. So next you also do your CNS exam, which is very important in a neonate. Okay, you have to assess for what is known as the anterior fontanelle, which is basically the soft spot of the baby. Okay, or where the sutures are not yet closed. Okay, so you assess how it is it soft, is it level? Okay, you assess the posture and the tone of the child. How is it? Is it a normal posture in the tone, or is there hypertonia? Is there hypotonia? You assess the primitive reflexes. Okay, and there you make your final assessment and your plan. Okay, as you can see, I assessed as early onset sepsis and neonatal jaundice, and that was basically my plan for the baby. Okay, so I hope this helps you guys. Just go through it and you get good at it. So now these are now different notes that we use for a patient who is on the ward. Okay, not admission notes but daily review notes. Okay, we use this form of paper where we indicate the date, day of admission, time, the age of the baby, birth weight, the current weight, the active problems where you put the problems that you're still solving, and then the resolved problems where you put the problems that have resolved. Okay, then there you put your IV access. Is there any? If any IV access, on which hand? The right hand. Okay, then you do your general exam, pallor, jaundice, anything you indicate. Okay, your CNS exam, just like I had explained. If there's any convulsions, you indicate. Okay, you do your respiratory, CVS, renal. Okay, basically, yeah, if the child is on antibiotics, you indicate. Okay, so as you can see what I've done there, that should help. Okay, so you just follow this and you're good to go. All right. Yeah, so here we just indicate what other medicines the patient is on. For example, this child is on nevirapine 3TC because the child is exposed. Okay, the mother is reactive, the child is exposed, so we put them on this prophylactic antiretrovirus. Okay, and then afterwards, you on your summary you can make your final assessment of what you think is wrong with the child. In this case, it was presumed early onset sepsis, dehydration, and exposed child. Okay, and you can also write in any other findings that are significant, for example, like ultrasound results, things like that. Okay, and you make your plan according to, as you can see, I gave the child the bolus of normal saline because of the dehydration at 20 ml per kg, TFI, full EBM, continued charted meds, and yeah. Hi guys, welcome back to another day of the vlog. So today is the 25th of July 2024, and time check, this should be about 22:30, and I am on night shift again. Yeah, so basically just sitting in the doctor's room. I'm about to sleep. Yeah, from reviewing one patient who came, a 3-year-old girl who presented with febrile seizures, one seizure which occurred at home lasting less than a minute. So this child has been having upper respiratory tract infections, and most likely I suspect that's the trigger, because for febrile seizures, you know, like they're most commonly because of infections, right? Yeah, so she came to the outpatient. Her vitals were within normal when she came. The temperature was 36.4, so that was okay. It wasn't high temperature. The saturations were okay. Everything was fine basically, and the child was stable. So I didn't admit. I just put her on a cough syrup, paracetamol syrup, in case of reoccurrence of fevers, and I drew bloods for checking for signs of infection, okay, or to see where the possible cause could be. All right, and I told them to come for review after 5 days. Okay, so for febrile seizures, the most important thing you should remember is just to screen the patient for the foci of infection. Okay, because remember, the febrile seizure is most commonly because of infections. Okay, yeah, and if the seizures persist, like in this case they didn't persist, but if they persist you can abort them using antiepileptics, okay, like diazepam, phenobab, okay. Yeah, so that was one of the patients I saw. She just left a few minutes ago. And then earlier on when my call just started, that was around 19, I admitted a 14-year-old boy for meningitis, and also I'm suspecting a cardiac heart disease. So this child presented with a history of having generalized headaches, which were initially generalized headaches, and then afterwards, sorry, they became more focused to the occiput, okay. So on and off, and then afterwards started having fevers, which were also on and off, which began on Monday. Yeah, so he says whenever he would have the headaches and the fevers, he would feel a little bit of neck stiffness, okay. And then he also says there are times when he would have dizziness and generalized body weakness, and then he'll feel what's the word he used? He says he would see things, so I guess like hallucinations, and then he would black out, and then after the blackout he would have memory loss for about 30 minutes or so. Yeah, so there's some CNS involvement there, right? Yeah, because that's already altered mental state, okay. And then what was the other complaint? Dizziness, yeah, I mentioned that. What else? Yeah, and then he also had some time when he sleeps in the night, he wakes up with difficulty breathing or gasping, right? That is what is known as paroxysmal nocturnal dyspnea, okay. So PND was positive, however there was no orthopnea, no limb swelling, but he says sometimes he would get easily fatigued when he just walks for a small distance, okay. So I was suspecting that it's like pointing me to some kind of heart pathology. And then on my examination findings, the chest was clear, his heart S1 S2 was heard, but then it was irregular, okay. So that's already one sign that also is making me highly suspicious of it being a cardiac heart disease, because of the heart which was irregular, okay. So what else? His abdomen, there was some tenderness, yeah, because he also presented with abdominal pain. So there was some tenderness in the abdomen, specifically on the left upper quadrant, the epigastrium and the umbilicus, okay. Yeah, mild tenderness, no guarding, just mild tenderness, no distension of the abdomen, just tenderness, okay, on palpation. And then on my CNS exam, okay, he's oriented to time, person, and place, okay. Yeah, because initially I was thinking like it could be some psychotic condition, but then he's oriented to time, person, and place. He's able to articulate himself well. What else? He's got a normal tone in all his limbs. Yeah, I think the only positive thing that I found on the CNS exam was the Koenig sign, which was positive, okay. So if you guys don't know about Koenig sign, I'll insert a picture somewhere here just to kind of help you understand what it is. Yeah, and Bradzinski was negative, okay, only the Koenig sign was positive. So that was what pointed me to suspecting meningitis in this patient, okay. Also there's also a positive history of his parent being reactive, okay, RVD reactive. Yeah, so I had to screen him for that also. Yeah, basically for these patients, basically for this patient, the most important test you're gonna do is a lumbar puncture, okay. Yeah, of which I'm yet to do that in the morning. Yeah, and then I also did a full septic screen on him, okay. So I collected blood for culture, I collected blood for full blood count, differential, group and save, RPR, okay, HIV test, hepatitis, okay, liver function tests, kidney function tests, okay. Basically just screening everything, okay. I collected urine for urinalysis and MCS. I also collected stool for MCS, okay. So these patients should do a full septic screen, okay. And then I also did a malaria MPS, okay. Yeah, so I did that, and then I put this child on ceftriaxone, okay. That's one of the antibiotics that you can use to treat suspected meningitis. Yeah, until we wait for results to come. Then we can know if it's bacterial, viral, or fungal, right? So I put him on ceftriaxone, 1 gram BD IV, okay? Yeah. Then I also put him on acyclovir, okay? Yeah, acyclovir, that was, I gave him 200 milligrams capsules, TDS. Yeah, usually for like 7 days or 14 days, okay? Even the ceftriaxone, okay? 7 to 14 days. Then I also put paracetamol, okay, just for pain relief and management. Yeah, as we wait for results. Yeah, and then also for the heart problem, I ordered an echo, okay? That is going to help us very much if at all there's anything wrong on the heart. An echo, a chest x-ray, okay, just to show if there's cardiomegaly also. And then we also ordered an abdominal ultrasound, okay, just to check if the abdomen is okay or what is causing the pain, okay? Yeah, so I think I've touched. Yeah, so basically that's what I did. That's how I treated this patient, and I've admitted him to the ward. So tomorrow morning I'll see him with my second on call, and then I'll most likely do the lumbar puncture then. And yeah, I'll vlog. I'll try to vlog, and then yeah, I'll fill you guys in. So for now, I hope you've learned a thing or two, and yeah, stay tuned. Hi guys, welcome back to another day of the vlog. So today is the 28th of July 2024. Time check, this is around 16:15. Yeah, I'm currently in OPD. That's outpatient. I've been here since 8 o'clock and I'll be here until 17. Yeah, so it's been fairly busy, not as quiet as I thought it would be. Yeah, it actually started off quiet, then I think around 10 I started having patients. Most of them just came with like upper respiratory tract infections, aka the common cold, aka influenza, and like flu, cough, fevers. So I was just literally just like prescribing cough syrups, paracetamol syrups or tablets. What else was coming? There was also like diarrheal disease, acute gastroenteritis. So I was literally like also just prescribing ORS, zinc, antibiotics if needed, paracetamol, all that stuff. Yeah, I only had one interesting case that came in. That was a case from Maramba Clinic. They were referred for severe dehydration. Yeah, so this was a 9-month-old male child who was brought in by the mother for, well, when you referred from Maramba Clinic, but then these patients came on their own. So I don't know why the clinic didn't refer them in an ambulance. Yeah, anyway, the child came with the mother, severely dehydrated, and we literally had to rush like to cannulate that child because the child wasn't even cannulated. Can you imagine? So we had to like cannulate the child, get IV access as soon as possible, and start IV fluids. Okay, so for severe dehydration you literally have to start plan C. Okay, so if you don't know what plan C is, just read up on dehydration. We literally have like 3 steps of management. There's plan A for no dehydration, there's plan B for some dehydration, and there's plan C for severe dehydration. Okay, so we literally had to start the child with plan C, which is literally like 100 ml per kg of IV fluids, which can either be Ringer's lactate or half strength diurese. Okay, but if you don't have those, you can even use normal saline. That also works fine. So we started this child on 100 ml per kg, and literally we divided that 100 ml. Okay, so how you give plan C: in the first 1 hour you're going to give 30 ml per kg. Okay, and then in the remaining 5 hours you're going to give 70 ml per kg. Okay, so you literally want to give this 100 ml per kg in a period of 6 hours. Okay, you give it slowly, you don't give too fast because you don't want to overload the child. Okay, so you give your plan C in a period of 6 hours, and you divide the 100 ml per kg into 2. Okay, so 30 ml per kg in the first 1 hour, and then the remaining 5 hours you're giving the 70 ml per kg. Okay, so that's what we commenced this child on. And then funny enough, I just forgot to mention, this child came with shock. Okay, this child was in shock because literally he had a temperature of 40 degrees. He was burning up, but then his extremities were cold. Okay, so his hands were cold, his feet were cold, he was lethargic, his capillary refill time was greater than 3 seconds. Okay, he had a tachycardia. Okay, so if you know signs of shock, you literally know that whenever a child presents with tachycardia, capillary refill time greater than 3 seconds, cold peripheries, lethargic, irritable, weak. Yeah, you literally have to know that that's shock, right? So we had to manage the shock first, and of which management of shock, you're also using IV fluids, okay? So you're giving 20 ml per kg of IV fluids, okay? Normal saline, Ringer's lactate, okay? And you give it as a bolus, okay? So for shock, you can repeat that bolus like up to 3 times, okay? Yeah, and then afterwards you can go to your specific plan of management, like plan A, B, or C, or whichever, okay? So in this case, we gave the bolus, we repeated the bolus 3 times, and then afterwards we commenced our plan C, okay? Because the child had shown improvement after giving the IV fluids. The extremities were no longer cold, the skin tegor had improved, the capillary refill time has improved, the tachycardia is literally gone, okay? And the child is now like active, is even like almost pulling out the cannula. So yeah, the child had responded to the management of the shock, okay? So I'm just from reassessing the child, and he's now even like awake. Yeah, so the parents just have to sit next to him and make sure that he doesn't pull out the cannula, because we had to put the cannula by the neck since we couldn't like get access from the limbs and stuff. Yeah, so the other thing you want to do for these children, if you're suspecting sepsis or infection, right? Because for me, I'm literally like managing this child as septic shock, okay? Because that temperature, 40 degrees is very suspicious. There has to be something causing the shock, okay? There has to be something causing the problem. So I literally collected blood for culture, okay? And then I also commenced the child on ceftriaxone, 50 milligrams per kg. You can either divide it into 2 doses or 1, so we just give it as a single dose, IV, okay? Every day you'll be getting that. We also put paracetamol for the fevers, that's 15 milligrams per kg. We also put zinc sulfate, okay? So zinc 10 milligrams per kg OD in children who are less than 2 years, and those above 2 years you give them 20 milligrams, okay? So we place this child on zinc sulfate at 10 milligrams OD per oral. And then we also commenced the child on what else did we put this child on? Panadol, zinc, antibiotics, the IV fluids. Yeah, literally it's just that, okay? If he can tolerate ORS, later on we'll try to give ORS for him to drink, okay? But if not, then we'll just continue the IV fluids for the next 5 hours, okay? Then we'll make our reassessment and see if we can switch to plan B or plan A or whichever, okay? Yeah. The other thing you also want to do is when you're giving your plan C, right, you have to make sure you're monitoring this child's vitals every 15 minutes, okay? You're checking the hydration status. How are the mucous membranes? Are they improving? How is the skin tegor? Is it improving, okay? You check the capillary refill time, you check the temperatures, the vitals, the saturations, okay? Yeah. If they're desaturating, you put them on O2. This child at one point was having saturations at 80%, so we had to commence O2 via nasal prongs, and currently the sats are now 96, 97, 98, okay? So there's some improvement there. What else are we doing? Yeah, you collect your blood for baselines, okay? Your full blood counts. You want to check your hemogram, okay? You check what's the problem, okay? Yeah, you check your liver, your kidneys. You do blood grouping and saving in case you want to cross match this child, okay? Remember I said like sometimes the shock might not be because of hypovolemia. Sometimes it might be like a type of shock that requires you to transfuse the child, okay? Yeah, so in this case my child responded to the IV fluids, okay? But in some cases like septic shock and stuff, they might not respond to IV fluids, so you might need to just give blood transfusion and antibiotics and all that stuff. Of course, as I'm managing my child as septic shock, because I'm really suspecting that there's some sepsis there, okay? Yeah, but my child responded to the IV fluid, so plus minus septic shock, okay? Yeah. Then what else? Yeah, you collect your blood for baselines, you collect your blood culture, you literally do a septic screen, okay? Because you're managing a septic shock. So septic screen, malaria, urine, stool, MCS, okay? Malaria, MPS, okay? All those things you do. Yeah. So that's just about it. Yeah, that's literally what I've been doing the whole time. The rest of the patients who came were just literally the cough, flus, the common cold. Yeah, so that's been my OPD. I'm now literally just waiting to knock off, guys, because I'm tired. Like this baby who came with severe dehydration literally made me run up and down, because we're like trying to get IV access. So yeah, I'm glad the child is okay. I'm glad we've managed with the nurses. We worked as a team, and yeah, we helped the child. So yeah, I hope you guys have enjoyed this vlog, and I hope you guys have learned a thing or two. Yeah, please do let me know what other things you might want me to cover in pediatrics. I can make other videos and discuss and everything. So yeah, I'll end the vlog here, and I hope you guys have enjoyed it. Please do keep subscribing. Yeah, thank you to my new subbies, and thank you to you guys who've been here from day one. You are the real OGs, okay? And yeah, let's keep growing. Let's get to 1,000. And yeah, can't wait for our giveaway, guys. Okay, I'm really planning something nice for you guys. Okay, so yeah, let's subscribe and let's keep sharing, liking, commenting, and yeah, I'll catch you guys in my next video. For now, it's bye.
I don't know how we got here, but been going through the phases, baby.